Good morning, everyone. Thanks for joining us, and you're all very welcome. My name is Dr. Nigel Little. I'm a consultant clinical psychologist within acute neuropsychology services in the Belfast Trust. It's my pleasure on behalf of, first and foremost, FND MattersNI and in association with the Belfast Trust and the Lottery Community Fund, to open this, our third annual FND Awareness Conference in Northern Ireland. It seems a bit of a world away now, but last year's conference was at the start of March and it was held in Belfast. Now, that event was at capacity with 120 attendees, and the audience was made up of people representing people living with FND, their families, a wide range of health professionals, charity representatives, and the Department of Health. Now, this year, the numbers have grown again, and I was checking there this morning, we're about 200 people registered to attend with us today, and with more interest developing through the morning. So if you were there last year, you'll hopefully remember that it was a really stimulating and informative day. I'm confident that today you can expect more of the same. Now, less than 2 weeks after we had the conference last year, the seriousness of the COVID-19 pandemic was really brought home to us as the UK entered its first lockdown. And it has been an extremely challenging time for everybody as the pandemic has unfolded locally and across the world. And I think all of us had some experience of what it's like to live with restrictions, to suddenly not be able to do the things that we want to do in our normal lives and not to be able to go about our business as we expected, and to be living with uncertainty, fears about our health, fears about the future. And unfortunately, these are challenges that people living with FND already knew about all too well, and challenges that they'll continue to face as hopefully we move through the lockdown and hopefully beyond COVID-19. So a lot has changed in the world in the last year, but what hasn't changed is our commitment to, alongside our friend partners in FND Matters, our medical colleagues, people living with FND, to continue to try to raise awareness about the condition, to work in collaboration with people to increase understanding about FND across the entire medical system and in the general public, to raise awareness, to challenge stigma and misunderstandings about the condition, and importantly, to advocate for the commissioning of services as well as improving the experience of people living with FND wherever they enter the health service. I'm sorry to say that there is a significant amount of work still to be done in this area locally, but I do remain hopeful that progress can be made. Locally, we have the Regional Review of Neurology Services, which is ongoing, and that's allowing us a platform to raise the profile, the need of people with FND, and to advocate for better services, ultimately for better outcomes for people living with this condition. So, just to take through today's program, after I speak in our first presentation is just an update from FND Matters NI. We have Frida, who is a member of FND Matters NI, and she'll be joined by Raymond. And Raymond is one of 4 counsellors now that has worked with FND Matters NI to provide counselling services locally. And Raymond will mention, but throughout the day, you will have got a link, hopefully with your invite today, with a link to breakout rooms where you can access the counsellors throughout the day today. So Frida's going to just give us an update, and she mentioned to me last night that I had suggested at some point we would be trying to produce a kind of new suite of information locally for people with FND, and she definitely wasn't going to let me forget it. So she wants to mention that we have a commitment this year to produce new information materials. Later this year, through the FND Matters website, I hope we will be putting a survey just asking for people to contribute ideas, information, things they would like to have known when they were first diagnosed, or things that they would like to know now. And throughout the day as well, the questions that you'll submit through the conference, they will be stored and will also help inform us moving forward. So after that, we're going to have a presentation from Professor John Stone. And he is the author of the newsymptoms.org website. And it's fair to say that he's probably one of the foremost people in the world who has internationally provided information, research and support to people with FND. I did look at his website last night just to look at the hit count, and it's actually running out of numbers, reading at over 9 million hits to the website. So Dr. Stone's going to give us a talk helping to explain FND, and the format this morning will be about half of that session will involve a presentation, and then we will have about half the session for questions and answers. So I just wanted to direct you at this point to the Q&A function. So your screen should look something like this, and you should see a question and answer button. And if you click that, then that will allow you to submit questions throughout the day that we'll monitor. Now, most of these events, we always have more questions than time. So we'll try to get through as many questions as possible, but as I say, we will have a record of those and can try to address some of those later, and they will help contribute to development of new information for people with FND. Okay, so after that, we're going to have a break, and we're going to be joined by Glenn Nielsen, who's a senior lecturer in neurophysio at St. George's. And Glenn has been over with us before to present in Belfast, and I've been over to visit him with our service in St. George's. So it'd be really nice to welcome him back. He's going to again have the same format, talk to us about physiotherapy for FND, as well as a questions and answers session. So then we'll have a break for lunch, and after lunch then we'll be joined by one of my colleagues here in Belfast, Dr. Enda Kerr, who is a stroke physician in Belfast. And we know from UK research that one route that sometimes people with FND enter the health service is via stroke services. So one study estimated around 8% people that come in suspected acutely of having a stroke are actually people with FND. And so Dr. Enda Kerr has been really central to helping develop FND Matters NI. He was really the link person between myself and Nat in setting up FND. So I think that it's really great to have him with us today. The support has been great over the years, and so he's going to talk a little bit about diagnosis and his journey, or physician's journey into FND. And then after that, last but certainly not least, I'm really looking forward to welcoming Judy Turnbull from the Patient Client Council. Johnny I know for many years from his previous work in brain injury, and he also was sort of central helping us originally with counselling for epilepsy and also for the counselling service for FND. So he's going to open that session, and then Jeanette from FND Matters is going to present kind of an in conversation with a number of experts through experience. So people living with FND or living with someone with FND. I'm really looking forward to that session. So we're going to hear sort of just a conversation and experience from sort of the other side. And then we have a little bit of time at the end where we can look at any questions that are remaining and a little bit of discussion, and going to close up around 3:30. Now, not all the speakers are going to be able to stay with us all day, so that we're going to have questions and answers as we go. But myself and the team will be monitoring the questions all day, and we'll try to get through as much as possible. So listen, thank you all for joining us, and hopefully you really enjoyed today. I'm certainly looking forward to it. So I'm going to hand over now to FND Matters. So Frida and Roland are going to join us. Thank you very much.
Good morning, everyone. Welcome to our third annual conference. My name is Frida Carson, and I'm the co-founder of FND Matters NI, along with my daughter Jeanette. You'll hear from her a little bit later on. This year's conference is slightly different from last year's. Little did we know what was in store for all of us. but it's amazing how quickly we all got used to a different type of communication. Last year, we hadn't heard of Zoom, and this year, Zoom is the new buzzword. Up until March last year, we were running a drop-in in Belfast. That has now been replaced by a weekly peer group. This has enabled us to keep in touch and support each other. It's been absolutely brilliant. We had great plans for 2020, but unfortunately, COVID put them, along with other things, up in the air. Our aim was to have a volunteer counsellor on board in April of last year. This didn't happen, but fortunately we were able to bring one on board in October. This has been quickly followed by 3 more volunteer counsellors, all trained by Jeanette and Dr. Little. We also have 2 befrienders on board, both well versed in FND. One of our counsellors will be speaking after me, and he'll be able to give you details about applying for this service. We are delighted that the feedback we have been getting about our counselling service is very positive. Jeanette and myself have been busy behind the scenes this year, getting involved with various other causes like dysphagia, No More Silos, which is about A&E and the changes they want and need to bring in. Candor Policy, Research Initiative. We're also members of the Northern Ireland Neurological Communities Alliance. And in doing so, we've spread the word about FND. We've also been involved with the neurology recall and have spoken to Minister Swan and Dr. Michael McBride to reinforce the devastating impact the recall is having on FND patients, and also bringing to their attention the lack of resources for FND patients. We have also joint initiatives planned with Dr. Little and the Belfast Trust, such as the launch of new brochures which will be available to anyone diagnosed with FND. As up until now, no information, as you all, I think, know, was available to patients. Our big announcement today is that we are starting a peer support group for our younger FND patients. Today you will hear from a 16-year-old trying to manage her condition whilst trying to continue her education and the struggle she's experiencing. And only for the support of a brilliant caring family, she would not be as upbeat as she is. Nicole has volunteered to help set this group up with our support and the support of one of our counsellors, Natasha, who I believe will be able to help them with free outdoor digital advertising, whatever that is. We're absolutely delighted about this and hope to be able to support and help other young people with this debilitating condition. Nicole, along with Lucy, another young person with FND, have set up an Instagram account in order to reach out to other young ones in the same situation as themselves. This is now live. We have lots of plans for the future, and with a bit of luck, a fair wind and the National Lottery Community Fund, we might just achieve this. Our dream is to have the funding to be able to have premises of our own. We would then be able to employ 2 workers. One would have control over the admin side, collating and managing records, promoting FND by assisting and giving talks to medical professionals, groups and colleges, and assign support and benefit. They would also be responsible for organising counselling sessions and alternative therapies. And in fact, we do have a volunteer able to provide these therapies, including touch therapy, which has been proved to be very beneficial. We are also looking at the possibility of equine therapy, as we have had glowing reports about this. Our other worker would be specifically charged to support patients and their families in managing this complex condition and to liaise with neurologists, neurophysiotherapists, occupational therapists and GPs in order to find the best way forward in bringing this debilitating condition to the attention of the general public. At present time, there is no pathway for FND patients, and this is something that must change. We need to keep challenging the medical professionals and the health boards to get proper procedures and help in place. Of the 200 who have registered today, approximately 1/3 are health professionals. This is very encouraging, and I would ask you if you would like to volunteer with us, and by doing so spread the word about FND, please contact me. FND Matters is committed to supporting, mentoring and advising FND patients, but I'm afraid we've still a long way to go. There is so much more that we can do, but we do need support from you all. Before I hand over to Raymond, can I just thank you for taking the time to attend, to the National Lottery Community Fund for their support, Bombardier for choosing us as one of their designated charities, and any of you who have donated. Also, the PCC for their support, our speakers today who have so generously given of their time, and lastly, our FND family who have supported us and hopefully will continue to do so. Thank you. I'll hand over to Raymond now.
Thank you, Frida, and good morning, everyone. May I add my thanks to you all for coming along today. My name is Raymond, and I am one of the counsellors at FND MattersNI. I started counselling clients through Epilepsy Action and Headway, and have since then worked with PIPs and crews, whilst also working with FND MattersNI. I had very limited exposure to FND at that point. I'd worked in a company which by chance employed 2 people into the same team who had FND. I remember the instant bond and friendship these 2 colleagues shared, and their relief at discovering someone with the same diagnosis, not just within the same company, but within the same team, and how unlikely that would be. These 2 individuals allowed me to be curious about and attempt to become educated about their condition and how it impacted their lives. I am forever grateful to them for their patience, openness, and honesty in answering any question that I had, and for sharing with me a glimpse into how living with this chronic condition impacted upon them, how others perceived them, and their journey to diagnosis and understanding and acceptance. Through my work with Headway, I was then introduced by a mutual contact to Jeanette and Frida. Another dynamic duo who inspired me with their commitment and determination and a vision which was infectious. Their goal of championing FND patients and providing support in all aspects was and continues to be remarkable. Part of that goal was to ensure that counselling support would be made available to anyone with an FND diagnosis or their carers or family members, and I knew that if I could play a small part in helping them to achieve that goal, that I was already hooked. I cannot overemphasize how these 2 women selflessly and tirelessly give to this charity and to the promotion of awareness of FND within NI, and I salute them for this. I feel truly privileged to play my role within this charity. So what is counselling? For me, it's about a meaningful person-to-person connection provided in a non-judgmental, confidential, safe environment. The counsellor's role is to provide the client with the environment to explore issues past and present that they are encountering. We do so in a non-directive way, allowing the client to come up with solutions that best fit them. We question, may challenge, may set homework, allowing the client to consider options and arrive at the solution that best fits their needs. Ultimately, we are a companion that will offer to walk alongside the client on their journey for a period of time when they may need an ear to listen. It is not a passive process. It is challenging and at times uncomfortable, but the counselling works at your pace and is respectful of your boundaries. At FND Matters NI, we are a small team of 3 qualified counsellors and 1 final year student counsellor, all of whom are registered and regulated by professional bodies working within and to their ethical and professional standards. We all attend regular supervision and work within an integrative framework, which means that we have been schooled in 3 main approaches of counselling, which are person-centred, CBT, and psychodynamic. We offer an initial 6 sessions, which can be flexible and tailored to suit needs. The sessions last for approximately 50 minutes each and will usually be at the same time agreed each week. Since starting to offer the counselling service back in November 2020, just 6 months ago, we have delivered over 100 hours of counselling and counting to over 20 clients. All of our counselling team have also attended bespoke training on FND, some kindly delivered by Dr. Little. We are not medically qualified, nor are we FND experts. However, we are aware of the challenges that living with FND can bring, and also the frustrations that some will have experienced to even arrive at their diagnosis of FND. This enables us to be able to say that we have an FND aware team of counsellors, which unfortunately is fairly unique within NI, and yet remains a vital and important offering. Today we have a chat room set up, which is a private space for anyone interested in either finding out more about the service or to make a referral to have counselling provided. Equally, we know that the topics covered today may be challenging for some, and if at any point you feel you would like to have a conversation, depending upon demand, obviously, a counsellor will be available. Details of the room will have been emailed out to you with your invitation. To be clear, we won't be offering any counselling today, but if you would like to have a chat or find out more about the service, we have a room set up to enable that to happen. If you would like to register for the counselling service post-conference, then you can either make a referral today through the private room, or you can email the office at any time at fndmattersni@gmail.com. That's fndmattersni@gmail.com, and someone will make contact with you. Many thanks for your time, and I hope you all have a successful conference. And on behalf of all of the counselling team, we look forward to working with anyone who wishes to avail of the service. I'll now hand you back to Dr. Little.
Thank you, Frida and Raymond. That's a great update of all the excellent work that you've been doing over the last year. So thank you. So next, it's my great pleasure to introduce Professor John Stone, who is an NHS consultant neurologist, an honorary reader in neurology at Edinburgh University. Professor Stone has been involved in significant amounts of research and clinical practice within functional neurology from around 1999. In 2009, he set up neurosymptoms.org website, which has been well received internationally and has been a significant resource for patients and professionals across the world, translated into at least 12 languages. His work, his team have made major contributions to the understanding of functional disorders, epidemiology, and approaches to treatment. So it's great to have him with us today, and I would just like to thank him for taking the time to join us. So to say, he is going to give a presentation for about half an hour or so, and then we will take questions as we go. So let me welcome Professor Johnson. Thank you.
Thank you very much, Nigel. Hopefully you can all hear and see me. So it's a great honour to be invited here, and wonderful to hear about the work that's going on, and particularly your counselling team. I would say not only unique to Northern Ireland, but I'm not sure there's many places that actually have even your setup there, which does of course tell us something about the general lack of services for this disorder. So today I'm going to be talking, I was asked to give a sort of general introduction to FND. I'm going to do that from my perspective as a neurologist, and I'm partly wanting to sort of let you see behind the curtain a bit, just to see what sort of challenges do we have as neurologists in making this diagnosis and communicating it. Because I think the more that people with FND understand that, the more we can work together, hopefully to try and treat your conditions. So I've got an introduction to FND, talk a bit about how common is it, how do we make a diagnosis. I'm going to try and take you through what we've learned about the causes of FND. It is a complex disorder. There isn't just one cause, there's many causes. And give an introduction to treatment, but you'll be hearing more about that later, of course, and some thoughts on the future. And I've also got some slides about some ideas about what to try and do when you can't access treatment. I know a lot of patients out there waiting for treatment in limbo. I did just want to mention a couple of things. It's a sign perhaps of the developments in this field that we now have a new international society called the FND Society. We started that a couple of years ago. It's for health professionals because we need to get our house in order here. And it's going very well. We have about 800 members internationally. There's a lot of enthusiasm from health professionals to become interested in this. There's still large area, I'm aware there's lots of places where there's no enthusiasm from health professionals, but I would say things are changing. If you do want more sort of academic detail about FND, do feel free to send me an email. I can send you one of these articles. I've got a whole book here on FND written for health professionals. Might be heavy going for a patient, but if you're I know many patients like to read what we're writing about it and look, see what follow through on these sort of leads. So yeah, please do send me an email. I'm just going to start with a patient. There are various videos in this talk. All of the patients featured in them have given their consent for these videos to be shown. Most of the videos are also published. So this is Lucy, who actually went on Radio 4 to talk about having FND. So I'll let her tell you what happened.
Basically, I'd woken up in the morning and I'd had a mild sensation of numbness in my face, but just assumed I was tired and didn't think anything of it. But by dinner time, my daughter, who's 10, had looked at it across and said, Mum, are you okay? Because my whole face had drooped on the right side, and then became aware that my right arm wasn't functioning either. And my husband, of course, panicked and called an ambulance, and they took one look and said, you've had a stroke, we're taking you into the hospital.
So Lucy had a presentation which suggested a stroke, and you'll hear more about that from Dr. Kerr later. In fact, the weakness came on rather gradually, which was different to many strokes. Lucy was interesting because, like many people with FND, she actually didn't have many of the sort of traditional risk factors for FND. She didn't really have a prior history of other health problems. She wasn't under particular stress. It just kind of happened. I think she was probably very tired that morning, but it was a slightly random out of the blue event, as it often is.
Show me your teeth.
Now, I'm just showing you here. This is one of the themes I wanted to get across here, is that in the past, certainly when I started, FND was thought to be a diagnosis that you made when all the tests were normal and you didn't know what else to call it. Now that is just wrong. And in fact, even 100 years ago, neurologists had recognized that you should really diagnose this disorder on the basis of typical features of the condition. So it's not a diagnosis of exclusion, it's a diagnosis of inclusion. And I'm going to show you some of the clinical signs that we use, and I hope it's okay to show these. I know sometimes showing other people with disabling symptoms can be quite upsetting. Like I say, all the patients have given their permission, and I hope it is instructive. So Lucy, you can see here, although the doctors thought her face was drooping, in fact, what's happening is that there's contraction of the muscle here on the neck, and it's pulling her jaw over to one side and her mouth down, and it's giving the appearance of facial droop. But that kind of spasm of the face with the jaw across to one side is something that you really only see in FND. So it's a positive clinical sign of the diagnosis.
And just try and keep your mouth in that position and then relax. And that does seem to have made it a little bit worse. Can you have a look? Can you feel the contraction?
Yeah.
Yeah. Just show me where you feel it contracting.
I feel it here.
Yeah.
And then it starts to come down here.
Yeah.
So she also has a sign which is called Hoover's sign, that is one of the most helpful and common positive signs of FND. And here I'm showing Lucy's Hoover's sign and also explaining it to her, which I think is really important. So in this test, the patient can't keep their foot on the ground because their leg is weak, and I'm trying to lift it up. But when I lift up the other leg, it comes back to normal briefly, and I'll hopefully you can see this in this video.
As hard as you can, that's normal.
Normal on
Push
the left.
this heel into the ground as hard as you can. That's weak, okay. And then
On the right side.
just lift this knee up for me. Keep it in the air. Stop me from pressing down. Focus on that leg. Really stop me from pressing down. And when we do that, you can feel that the right leg returns to normal.
Mm-hmm.
Okay. That's good.
What we're seeing here, and this is difficult for many people to get their heads around, but what we're seeing here is that in FND, when people try to make movements, if they've got limb weakness, the more they try, the worse it gets, because their voluntary movements are impaired. But their automatic movements are often normal. So lifting up their good leg just happens to bring out that automatic movement briefly. So it's showing us that there's a potential for an improvement there. And it's showing us about something about the nature of the condition, that the brain is working too hard on movement, in fact, even though it's weak. So Lucy had FND. She didn't have a stroke. She did have a normal brain scan, but that wasn't how we're making the diagnosis. Making the diagnosis based on these positive signs. Even if she'd had a small stroke, she still would have had some FND as well, based on those signs. And she did quite well in the end, and actually didn't. She was an example of a patient that benefited most from physio, and there wasn't a lot of psychological factors in her case. In many patients, psychological factors are very important, and it should be the primary focus of treatment. So everyone's different, and we have to evaluate and treat people as individuals. So functional disorders are really common. I've said functional disorders, everyone's problem here, because almost everybody has a functional symptom or disorder at some time in their life. I would say migraine is a disorder of function, because that's another condition you can't see on a scan. I have quite bad migraine. I had a childhood stutter, which I think when I was a university student returned as a functional disorder. So those are two of my functional disorders. It's part of being a human being, I think, is to have these disorders which are defined by the fact that they relate to abnormal nervous system functioning. They're not, a functional disorder is not a synonym for a psychological disorder. They are a separate category, really, of conditions which the general public are not really very familiar with. And we tend to just divide things up into, you've got diseases that you can see on a scan, or you've got psychological problems. It turns out there's this whole other third category that's really ignored and accounts for up to a third of all visits to GPs and secondary care. It's a huge problem and quite amazing, really, that we don't talk more about it. In neurology, we found that FND is the second commonest reason to see a neurologist after headache. So this is not a minor, rare problem. This is what most neurologists are doing a lot of the time. And so it is surprising that we don't have better services. This is what surprised me when I was starting out in neurology. We're spending a lot of money on it. This was a study done this year or last year in the United States, just showing even in 100 million people in the United States, they were spending $163 million on emergency visits related to FND. They were spending $1 billion on FND inpatient treatment. Amazing numbers. $1 billion. Please, can we spend some of that on research, on developing better evidence base for treatments? It doesn't make sense to spend all that money and not to spend some of it on trying to improve services and treatment. Who gets FND? Men and women. In this study of seizures, what we showed was that women seem to particularly get it as a peak in teenage years, which gradually drops off. And actually, interestingly, by the time you get to people developing in their 40s and 50s, it's kind of equally male and female. So we're learning more about who gets it. And here's me in 2004. I was a registrar in neurology at that time, as my two boys there, my wife Pam. And I put this up just to remind myself what was happening at that stage with FND. So I know there's a huge amount of frustration from patients about, just being given a website or not accessing treatment. But I can tell you at that stage, you could not open any neurology textbook and read about FND. You could not open a neurology journal and read about it. There was nothing. And I was frankly amazed as a trainee that I would be on the ward round or in an outpatient clinic seeing patients who clearly had these disorders, which neurologists were recognizing but not really labeling, and just ignoring and not providing anything, no information, no treatment. So things may seem bad now, but they were even worse before, I would say. These disorders are often stigmatized and ignored. Doctors still routinely say to patients, there's nothing wrong, tests are normal, goodbye, or it's just stress. We have to be careful here not to stigmatize psychological problems, psychiatric problems. They often are relevant, may not, as you can see with Lucy, may not be relevant at all. But doctors have had a tendency to assume that everything's always psychological, and that's often caused a lot of difficulties as well for patients. And this is a survey from FND Hope, over 500 patients with FND, but 80% of them saying that they'd felt dismissed or disrespected when visiting a medical professional. It's pretty scandalous, really, that this is going on, that we have a disorder where people, it's almost a sort of, I hesitate to use the word apartheid, but it is a slight medical apartheid, where people with a functional disorder are treated less well than people who've got something you can see on a scan, even though they have the same symptoms and the same disability. So I'm going to introduce you to Rachel, who very bravely helped us make this short film that you can see on neurosymptoms. Rachel is a university student, and you can see she's got weakness down her right side, and she's just showing us the problem here and talking a little bit.
In an ideal health service, all doctors and professionals would be actually made aware of this, and we wouldn't be treated as though, not like we're faking, but almost like as though it's not real, and that doesn't really help us, because we're thinking, oh, what's wrong with me? So now I'm going to talk you through a few key points about FND in terms of what we've learned about it and things to establish, because and many times health professionals still get these things wrong. So it's not a diagnosis of exclusion, as I've already started to tell you about. And here's Rachel again. She's got another sign here. It's a bit like the Hoover sign, called the hip abductor sign. And it's showing again that she's got a problem with voluntary movement. The more she tries to move, the worse it gets. But the automatic movements are better. So let's just have a look at this. So can I just get you to push against my hand here? We can see when we do that, you're stronger than I am. Yeah. And I can't push that knee in. And then let's try and do the same thing with this knee. So stop me from pushing in, push out as strong as you can. But I'm winning there, pushing your knee in. Let's go back to this side. I want you to push out again as hard as you can. Really stop me, push, 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 push. Now when we do that, we can see that actually what's happening over on the right side is that it's become much stronger and I can't push the knee in now. Mm-hmm. So it's brought out the automatic movement. So you might be saying, why am I showing you these neurological signs? I think it's because they're so important for understanding the nature of the condition, understanding
why a diagnosis has been made, but also you can start to use these in treatment. So if there are maneuvers that help to bring out automatic movement, just briefly, well, wouldn't it be great if we could use those maneuvers somehow in physio to promote automatic movement? And that's exactly what Glenn Nielsen, who you're going to be hearing from after me, has led in developing. Tremor is one of the commonest types of FND. And this is a gentleman who's got really bad tremor. And you'll see in this video a test that we do to diagnose functional tremor, asking the patient to copy a movement that you're making. And if you speed it up and slow it down, and then see how that interferes with the tremor. And again, it's something that friends or family of someone with FND could experiment with and see if it changes it.
86, 79, 72.
So in fact, mental arithmetic isn't really changing, but as soon as this gentleman copies the movement, you can see his tremor improves a lot on the left there. And now it's going at the same rhythm as the examiner. And that's something that only happens with functional tremor. And I would encourage anyone listening who's perhaps working as a counsellor or in therapy, these are things that you can explore with patients yourself, particularly when you're starting to wonder, is there any possibility of improvement? Is this something that can be changed or modulated? These kinds of physical signs can help with that process. Now again, I do a bit of a warning to the audience here, because we do have a patient here with a seizure, and it can be upsetting to watch someone have a seizure, but I think we need to see, this is the realities of this condition, is that seizures are probably the commonest type of FND. And I'm just going to let this run without the sound. And it's very kind of this patient of mine to share this video. The point here is that although it looks a bit like an epileptic seizure, there's lots of things happening which are typical of FND. So he's got his eyes closed. He's actually got a tremor-like movement. He's breathing quite fast. He has side-to-side movements of his head. The episode's going on a long time. He's partly aware of what's happening. So these are all things that happen in FND seizures that don't happen in epilepsy. It's not about the fact that it's not epilepsy. It's about the fact that it is FND. And these are some of the things that we look for, the eyes being closed. It is difficult, and there are patients, for example, who have their eyes open or have short events. So don't look at this and try and, these certainly are things that need a neurologist to sort out. But I want to give you an indication of the sort of things that we're looking for. And there's many other types of problems that I haven't got time to talk about today, which I'm sure many of you listening will have, problems with speech, vision, cognition, dizziness. And then there's all of the things that people with FND commonly have as well, like chronic pain, fatigue, functional bowel disorders, etc. So, and of course, other mental health problems, depression, anxiety, really panic, PTSD, all really common. Those are not core symptoms of FND, but they commonly go along with them. Something that doctors often mistake as well is that the idea that if you have FND, that's it, that's the only thing wrong with you. Many people with FND actually have more than one thing wrong with them. They have FND, but they also have chronic pain, and they also I have patients, for example, who have a mild MS and FND. And in fact, it's the FND that's causing most of the disability. So doctors shouldn't stop thinking when they make a diagnosis of FND. They should always think, what other condition does the patient have? This is an example of somebody who has migraine, and the migraine gives them left-sided symptoms, but then that triggers FND. So you can often see people, for example, who have epilepsy, that triggers FND. They've still got epilepsy. So we need to learn how to manage patients who've got these mixtures of symptoms, because they're very common. And some studies looking at that. I'll skip that. So I've said as well, it's a diagnosis of inclusion. The other area where doctors get this wrong is they look at the patient and they say, well, that looks really strange. I don't know what that is. That looks strange. It must be FND. That's also a big mistake. Here's an example of a patient who does have a very unusual problem. with their walking. But actually, this is a patient.
En graag nog één keertje op en neer als dat kan.
So in some patients with Parkinson's disease, you can see here looks much more like someone with Parkinson's disease. Some people with Parkinson's fluctuate between these being very stiff and slow and having those abnormal things. So this is I'm just letting you know what I try and teach other doctors about FND. It doesn't, I know that doesn't always come across, but this is what they should be thinking. Now let's just talk a bit about stress and psychological risk factors, because for 100 years this disorder has been considered to be solely due to stress, solely due to psychological factors, and I think that's been very limiting for the field. And it's for example, it's been one reason why neurologists have said, well, it's not my problem, because this is a psychiatric problem, a psychological problem. And I think what we've learned over the last 20 years is that that's not correct. Psychological factors are a strong risk factor for many patients and important, but not all of them, as you've seen with Lucy. And where is FND happening? It's happening in the brain. Where else could it be happening? So it's a disorder of the brain too. And this is a diagram that I'm going to walk you through this slowly over a few slides, because I want to try and help understand the disorder a bit more and how we think about how it develops. Etiology is why it happens, mechanism is how is it happening. Now there are a whole range of risk factors for FND, which include having other functional disorders that I've shown you, migraine, stress, childhood adversity, etc. But quite often, sometimes people have it with just out of the blue, with no risk factors at all. And what we've shown is that those risk factors are present, and they're probably similar. Things like adverse experience are similarly present to people with depression and anxiety. So they are present, but not in everyone. It's a bit like if you have a stroke, how likely is it that you've been a smoker? Well, it's more likely that you've been a smoker than other people, but plenty of people have a stroke who aren't a smoker as well. So we have these vulnerability risk factors, but then we should be thinking about triggering factors as well. And I want to just introduce you to the idea of dissociation, which I think is an important symptom. This is a feeling of disconnection, either from the world around you, derealization, or from your own body. It's really common in FND. It's a natural human ability that we have to disconnect ourselves from our body or environment, particularly when we're under threat. And this is what often activates abnormally in FND. And what we showed is that a lot of patients with FND causing movement are there's often a physical trigger. So there's often a physical injury or an infection or a drug side effect or migraine. People have kind of ignored these physical triggers in favor of the psychological ones. We need to put them all together and understand each patient individually. I'm going to skip that video actually, just in the interest of time. So we should be thinking about triggers as well as predisposing factors. And what about the brain? Well, where else could it be happening? What other organ in the body could these symptoms be coming from? Why have we not been talking about FND as a brain disorder? It must be. And in fact, we do now have good evidence that there are disorders, there are changes in brain function in functional disorders. That's not surprising. They are mostly changes in function, so changes in the kind of software or the programs that the brain is running. A bit like when your computer goes wrong, it's not normally smoke coming out of the back. It's normally that horrible blue wheel going round and round, and you can't get, and the program's frozen. You see the problem on your screen, a bit like you might feel the problem in your leg, but actually the problem is in the computer box, which is your brain. And I'm not going to take you through these, but there's just an example of a nice study of patients with FND, about 40 patients, just showing areas in the brain that are just not working properly. And it's particularly areas, the parts of your brain that map your body and tell you that it's you doing something. Those bits have gone wrong. There's abnormal connections that we've seen between parts of the brain related to emotions and memories and movement. So we've still got a lot to learn about this, but I think there's good evidence of a disordered brain function. And something else that's very important here is there's good evidence that the changes in FND look different to people pretending to have symptoms, even though clinically, sometimes if someone was pretend to have a leg weakness, they might look similar. This is not pretending, and the brain studies show it. Another way of thinking about this is to think about the condition phantom limb pain that you may have heard about. So people who have a amputation because you know, the soldiers or diabetes or something will often still feel as if the leg is still there, and it's a really painful, distressing problem to have. Now, why is that? It's because we have a map of our brain, our body in our brain, and our brain just predicts things. It spends a lot of time working out what's about to happen or what should happen. So in phantom limb, the brain predicts that the leg is there. Even though the leg isn't there, the brain ignores that sensory information and carries on predicting that the leg is there. And so that's why you get that sensation. In FND, it's the opposite problem, really. The leg is there, obviously, and the sensation is there, but the brain is predicting that the leg isn't there. So, and again, it's the same sort of mechanism. I'm going to skip. I want to make sure we have enough time for questions here, so I'm skipping on a bit. So in FND, we should think of problems like depression and anxiety and sleep problems and pain as comorbidities, things that commonly occur, but they're not necessary for the diagnosis. They may not be present. Sometimes people make that mistake, I think. And then we should think about things that keep it going. So what's really tragic for many patients with FND is it's bad enough having this out of the blue, but then it's all made a lot worse because they don't get a diagnosis. It takes years to make one. People hedge their bets, or they get put on medication that might make things worse rather than better. They might have unnecessary treatments or surgery investigations. These are all things that tend to make things worse. When you've got a disorder where your brain isn't working, this just scrambles it even more. So often by the time someone is diagnosed, you've got a lot of things to untangle.
Professor.
And just try and summarize what is FND. Is it coming, patients will often ask me, so is this a brain disorder or a psychological disorder? And I like this clip of Harry Potter and Dumbledore because it kind of answers the question.
Professor? Is this all real? Or is it just happening inside my head?
Of course it's happening inside your head, Harry. Why should that mean that it's not real?
So it is happening inside the head, but that's where your brain is. So this is, and I'm afraid that people still really struggle with these ideas. So treatment, just an introduction to treatment. This is a scheme that we put together for Health Improvement Scotland a few years ago. And the radical thing, believe it or not, and this was to say that the neurologist should be involved in the initial management, because many neurologists don't feel that it is their job to be involved, or that it's just their job to make a diagnosis. I feel strongly it's not. I think the neurologist is well placed to think about triaging for treatment, see the patient again, help understand the disorder. And these are some slides that I use with doctors when I'm trying to help them with communication. I'd be interested in your feedback on this, but many things go wrong, and I'm showing this partly to see perhaps that some of these things have happened to you if you're a patient listening to this. So often doctors carry on doing tests. Now, tests are important. You should usually do tests in FND because you want to see, has the person got a neurological has got another neurological problem. But doing tests over a long period of time is really putting patients in limbo. And as I've shown you, we make the diagnosis clinically at the bedside, so you should be able to make it straight away, and then say, well, let's find out if you've got another condition as well. So this often goes wrong, and it's pretty alarming when people are doing tests the whole time and you don't know what they're going to show. Some doctors will approach the problem by telling people what they don't have. Well, now it's helpful to know you haven't got Parkinson's, but if you've got the same disability as Parkinson's, you need to know what you do have, I would say. And then some people use words like psychogenic or conversion disorder. and talk about things entirely as stress. Now, that, I do meet patients where that might be a reasonable thing to do based on their own circumstances. But often patients feel when they're being talked to like this that they're being blamed for it, or it's their fault, or that they're being told they're crazy or made up. And so everyone gets in a lot of trouble here just with language. And what I teach health professionals to try and do is just treat FND like you would any other condition that you're trying to give a diagnosis to. So tell people what it is. Most people have never heard of FND, so they're going to be a bit surprised, and they'll need some time to understand what it is. But at least the doctor seems to know what's wrong here, and that the doctor believes you is, I think, very important. I've stopped saying this because hopefully it's clear when I'm talking to patients that I believe them. Showing the signs, as we talked about, so talking through the signs and how they help us make the diagnosis and what that's telling us about the nature of the disorder, that it's due to a software problem, not a hardware problem. And it's not due to irreversible damage to the brain. And this is a message that I think is important to bear in mind, however long you've had FND for, that these software problems do become very ingrained and they are very difficult to treat. And many patients, it's not possible for everyone to improve, but patients have the potential to improve for a long period of time. That's different, for example, to someone who's got progressive MS, where there is progressive brain damage. So that's an important thing to bear in mind. Software, not the hardware. So what I tell doctors is please treat FND as you would any other condition that you see. So just tell people what it is, explain how you're making the diagnosis, talk about what's gone wrong, but don't jump to conclusions about why, because that's complicated and it varies a lot from person to person. So I did make this website about 12 years ago now, because I was really struggling to get all this across in a half-hour consultation. We struggle as well with time that we've given to see people. And I'm pleased that it's been of some help, but I'm also aware that it's thrown at people without any treatment. So I'm aware of that more than anyone, I think. But there are some really helpful videos on there, so Alex Len, a neurologist in Brisbane, helped to make these, and I helped a bit with them. I think they're really a nice introduction for new patients. And I've got a world first for you here, which is a little sneak peek at our new Neurosymptoms app. So that, as you can see, that website's looking a bit tired. We've got a new version coming, which should hopefully be much easier to look at on phones. And this is the app that's going to go with it, which has been in development, and some money from the Scottish Government to help do this. So you can see we've got symptoms there, and videos, everything hopefully a lot easier to find, and some frequent FAQs. So I've been working away trying to improve this with a colleague called Pooja Jain. So I'm looking forward to launching that in the next month or two. It's a range of fact sheets here. And I'm aware that on the website there's a lot of information. It can be quite hard to find things. I'm going to try and make it easier for people to find things, and try and make it an easier pathway for patients to access information, particularly when they're not getting treatment elsewhere. I don't think a website is a substitute for treatment. It was only ever meant as a sort of support to people delivering treatment. I think it's wonderful that we have these organisations now for FND, which have appeared in the last 10 years. And I think it's great that we're working together with health professionals in this area. I think it's a model for that, which doesn't really, I'm not sure there's such a good example of that in any other functional disorder. These conditions have been so stigmatized. So I'm really excited to see where that can take us. And some other resources here, the MyFND app, I think is quite helpful for recording symptoms. People like FND Portal on Twitter, really positive about FND. And this is a new book, graphic novel for patients with functional seizures that I helped collaborate with. A story of, particularly for younger people, perhaps a story of of functional seizures, trying to help understand the condition. And it's brilliant we have people like Lorraine Kelly now helping to spread messages about FND. So when that goes well, this was a message from a patient of mine who had a functional speech and writing disorder, and she's written, have a diagnosis at last. Someone finally knows what I have. I know people go through a very long journey of feeling that no one knows what they have. How can you get better if you don't know what you have? I think it's just the first step. It's not the treatment in itself. And neither is a website a treatment in itself. And this was from FND Action. Someone scribbling on the front of the Daily Mirror the name of my website as a treatment. It's not. I think what's happened is that they used to do nothing, and so they feel like they're doing something by giving someone a website, but it's really not enough. Now in the last 5 minutes, because I do want to leave time for questions, I'll just talk a bit more about treatment, just as an introduction to Glenn. So it's a multidisciplinary problem. We do need psychologists, psychiatrists, but we also need physiotherapists, occupational therapists, speech and language therapists. The basic treatment of FND is rehabilitation. It's about treatments that help retrain the brain and make the brain work better again, more like its natural automatic self, and that tries to get rid of these abnormal programs that have got lodged in the brain and are causing all the symptoms. So here's a patient having physiotherapy for functional gait disorder, and you can see that he's relying on his elbow crutches here, not really putting any weight through his legs. He's lost all confidence in putting his weight through his legs. And Audrey and Melanie, who work in Glasgow, it looks like initially there's a weight-bearing grip here. They're offering support, but now they turn it into a non-weight-bearing grip. So the gentleman has to put weight through, but they're doing it in a supportive way. He knows what they're doing. He knows that they're trying to promote automatic movement, and you can sometimes get good results. And I hesitate to show this video because I know many of you would love to just get better like that. That doesn't happen very often, to be honest. But I think it makes the point that these sorts of treatments can make a big difference. Usually recovery and improvement happens much more slowly than that, and it follows a very up and down course. This is Claire Nicholson, an occupational therapist in London, who led on these consensus recommendations for occupational therapy, which I think can have a really big role to play in FND, because it's involving tasks and activities. So taking the focus away from the body. The more someone thinks about their legs, the harder it will be to move them, whereas occupational therapy is involving doing things, often tailored to the person's interests. And this is Kinjal Goyal, who's a neuropsychologist in India, who I've had some nice conversations with. She's doing treatments out there for FND. Many types of psychological therapy can be helpful for FND. How does that work? Is that really rehabilitation? Yes, I think it is. Is it retraining the brain? I think it can be. So if somebody thinks initially, I've got MS, I'm going to end up in a wheelchair, no one believes me, and then thinks, well, maybe I have got that FND thing, and they start to understand how things are worse when they're thinking about their legs compared to when they're allowing the automatic movements to happen. That is a form of psychotherapy, because you've changed someone's thoughts. That's a basic form of cognitive therapy, I would say. That's something that all health professionals can help with. We carried out, I was involved in this trial called CODES, which is the largest trial in FND. It was published last year for patients with seizures, and you can see the centres here that took part. Actually 700 people were initially put in, and 368 were in the trial. Now what we showed in that was that actually, and in fact both groups had quite high standard, high quality treatment from health professionals expert in FND. So in fact what we showed was that both groups improved, and the people having CBT actually didn't really improve more in terms of the frequency of their seizures than those who were just having the standard care. In some ways it's not a very fair comparison, because what's really happening out there is that lots of people with seizures are getting no treatment at all. So got to bear that in mind. What we did show was that CBT was better for a whole range of other outcomes, like how bothered people were by seizures, how they were feeling, what they could do at work and at home. So I think there is evidence here for CBT being helpful. And then I didn't want to ignore the things that go along with FND. So on the Neurosymptoms website or elsewhere on the Google, you can find this video called Tame the Beast about chronic pain.
So how do you know when your nervous system is learning pain? You may notice your pain comes on without warning. Your body feels odd and it's hard to move properly. Your pain changes quickly with your mood and small annoyances can set it off. Old injuries start to hurt again. You're more sensitive to stimuli. And the longer the pain goes on, the more all of this occurs. The old way we understood pain could not explain these things and left many sufferers feeling like no one believed it was real. Or for it to hurt so badly, there must be a major tissue problem. But we now know how persistent pain happens.
So that's a video I'd really encourage you to watch. It's made by Lorimer Mosley, who's a leading researcher in pain in Australia. So how do you... And then let's not ignore mental health problems, because they are common in FND and they do interact with FND and often need to be addressed, particularly anxiety, panic, previous trauma, depression when present. So many people don't have them, but if they do, let's discuss them too, because they're often important. Now, just the last couple of minutes, I just want to say something about what can you do when you have no access to treatment. I don't think any of this is a substitute for treatment, frankly, and I think trying to just manage this yourself, it can help, but it's very difficult. So I'm not suggesting that this is a substitute. But I do think the more that you can learn about your diagnosis and come to not accept that things always have to be the way they are, but learn that this has happened to you. It's not your fault. This is going on in your body. You can't just switch it off. That sort of acceptance, I think, can be really helpful. Many patients with FND I meet give themselves a really hard time about that, or they push so much. They're often sort of real doers and triers, I think, and need to learn to recognize that they're unwell and they have a condition and that they need to focus on getting themselves better. It's a roller coaster with FND. Things hardly ever improve in a straight line. They usually improve and then relapse, improve and relapse. It's really hard dealing with that. And recognizing that there are things that you really enjoy doing, to focus on those. People with FND, I find, are often very focused on other people and helping other people, and not so good at thinking about themselves. So this is the kind of roller coaster I'm talking about. And recovery, when it happens, can look like this. It doesn't look like recovery to begin with, because you get to here, you're still going back to square one. But actually, we're looking at a series of relapses that someone's learning to manage better with. And I was really delighted when someone knitted that graph for FND Awareness Month. That was great to see. If you've got seizures, here's some resources on neurosymptoms to have a look at and think about. But don't be despondent if you're making no progress. I think these things often do need someone. Patients need treatment. This is a complicated area. It needs time to understand and an external objective. So FND, positive diagnosis of inclusion. Neurologists, I think, should be sharing this transparently with patients, helping with supervising treatment and referral. I know that often doesn't happen. The models we have for this involve biology and psychology now equally. They should have equal partnership. And the treatment's multidisciplinary. And I really want to pay tribute to the team. I co-lead our group with Alan Carson, who's a neuropsychiatrist. We've been very fortunate to have lots of different visitors coming. I would say that both Alan and myself are full-time NHS clinicians. We've done this over the last 15 years, essentially more or less in our spare time. But I think we've done that partly because of the enthusiasm and energy that all of our visitors have brought to us. So I want to pay tribute to them. So I will stop there and stop sharing. And I hope that was helpful, and happy to take questions.
Thank you very much, Professor Stone. And I know how challenging it is to try to condense everything into such a short space of time, and I think you did a brilliant job of that. So I really appreciate that. So we have lots of questions coming through, and again, probably in the time we've got about 15 minutes left to try to tackle some of them. Some of them might be more relevant to later on as well, but if you don't mind, then we'll just take a bit of time to go through some of the questions. So Marion has asked a number of questions, and I suppose it goes back to something you had said about the idea of trying to get our own house in order, both in the neurology services and psychology services and physio. And she's commenting really about the training issues. It's a range of professionals in terms of FND, specifically in Northern Ireland, but be aware it would be an issue in lots of places. And I suppose you were highlighting the first sort of last 15-20 years, things have progressed significantly, but training maybe hasn't kept pace with that, so that staff that were trained and qualified many years ago may not have the familiarity with that. So I suppose I was just wondering then, the question is really about how do we manage to get message out and to train staff in FND?
Yeah, I mean, yes, it's a major issue, and to some extent it's an issue with older staff. There is a sort of issue of, can you teach an old dog new tricks, to put it bluntly. Sometimes you can't. One major coup I think that we've achieved recently is that FND is now going to be one of the 10 core conditions for neurology trainees in the UK that they have to learn about. It was previously very much a peripheral thing. You could sort of take it or leave it, kind of it. Now it's going to be a core part of training for all neurologists going forward. So that affects neurologists who are new or in their 20s. It doesn't necessarily affect the neurologists in their 40s and 50s that you're seeing. I do see a lot of interest from physios, OTs, psychologists in this area. I think they are ready to learn, many of them. They just haven't been able to access that. But there are things like the FND Society. We're doing, I'm up till midnight writing sort of review articles, and I did one last year for the British Medical Journal, which was the first one they'd had since 1953. There are these changes are happening, but I realise on the ground, you only meet the one person. If they're not interested, they're not interested. So it doesn't really matter for that person. But so I think developments are happening. Ultimately, these things will only improve if we have better evidence-based treatments, I think. And then people will really have to, which I think we already begin to have. And then people have to say, well, look, you cannot deny these evidence-based treatments to these disabled patients. It would be scandalous to do so.
Thank you. Okay, we had another question that was from G. Wilson, and they were just asking about your view on the management of more sensory symptoms, particularly sensory sensitivity and sensory sensitivity seeming to trigger other symptoms. Now, I recognize you can't comment on a specific person, but I was just wondering if in terms of what you advise people or sensory symptoms in terms of managing those, if you had.
Yeah, so I mean, I think the sensory, it depends what sensory symptoms you're talking about. I mean, the ones that bother people a lot, of course, are sort of sensory sensitivity to light, sound, movement. And I think there we're looking at a process of the thing that helps is a process of desensitization. So if someone's found they're very light sensitive and they're wearing dark glasses the whole time, you can understand how that happened, but the treatment does involve then helping that person to desensitize themselves very gradually, not suddenly taking the glasses off, but maybe getting slightly less dark pair, doing it sometimes. Same for touching a limb if you become very sensitive. Those are the key. It's a process of desensitization which can be done through psychological therapy or via physio or OT.
Thank you. Lindsay asks, she's sort of wondering about the minimum requirements of assessment to diagnose FND. So I recognize you've talked about the idea that in the past, particularly, FND often had a stigma associated with it, with the idea that it's sort of a dump category. It's a diagnosis is given when the doctor can't figure out anything else that is wrong. But what Lindsay was wondering about was how people are protected from that, so that people are not diagnosed with FND on that basis. So, I mean, I think you have covered for that, but if you would just like to say a little bit more about, I suppose, how the idea that everybody doesn't get diagnosed with FND. So you were sort of saying, well, it's kind of part of how the nervous system works, how the brain and the mind work together. And in some respects, everybody has elements of FND, but then some people have very specific symptoms and are troubled to a very significant level. So it's sort of where that line falls, or ideas.
No, and I appreciate, so diagnosis, misdiagnosis is an area that people, where people feel strongly about that. And of course you're going to, particularly if you've suffered from misdiagnosis in either direction. So if you are diagnosed with FND and then it turns out to be wrong, well, I can see why that would be very upsetting. But it's also very upsetting to be diagnosed with MS or epilepsy, as many of my patients are. And then years later, someone realizes that that diagnosis was wrong and it's FND. So those diagnoses go in both directions. They probably happen more the other way around, so that the FND diagnosis is missed. I think this is a question about accurate neurological diagnosis in general. So I don't think you can summarize in a quick checklist every patient should have this kind of test. You are relying here on neurological training, which takes 5 or 6 years of medical school and then 6 or 7 years of specialty training. That process is there to try and produce doctors who know what they're doing with diagnosis. And I know that doesn't always happen, but it is an art, it's a skill as well as a science, and it does, and you can harm people with over investigation as well. So, but as I do say in lectures, for example, if someone's got a functional weakness down one side of their body, I would always do an MRI scan of the brain, spine. That's my personal practice. I think we do need more research about investigations and their role. Yeah.
Thank you. So there's a number of questioners that are sort of, I suppose, all along a similar theme. So Claire, Luca, David have all sort of reflected on, I suppose, is something that we encounter, which is there's the presentation in terms of the reversibility of symptoms, or the theoretical reversibility of symptoms. And that people's bodies being capable, at least in some circumstances, of returning to normal movement, or at least temporarily having some of those errors corrected. But then the tension in the long term for people mentioning just about chronicity of motor and sensory symptoms, of working on mental health problems and trying to manage stress, but finding that the relationship isn't so clear with their functional neurological symptoms. And as the questions generally are about outcomes in terms of the idea of complete recovery, or people can be complete recovered from FND, or really is it should be something reviewed as a more chronic issue that is relapse remitting and have good periods and bad periods. And also, I suppose, that point of the acceptance of symptoms. So people getting to a point where should they accept, well, look, I've worked really hard on this condition, I still have symptoms, and maybe I should be focusing more on kind of managing with them. So perhaps if someone had a traumatic brain injury and had been left after several years with they kind of plateaued in their recovery, often we're assisting them to kind of adapt to their new established disability rather than straining against changing it. So sorry, there's quite a lot in that, but if you just maybe reflect some of the.
Yeah, no, thanks. I'm really glad you brought that up, actually, because I perhaps should have had something on that in my talk. We did a study on looking at people, following people up for 14 years who presented with functional limb weakness. And that's the longest prospective study there's been of this condition. And actually, the news wasn't great in terms of what's the long-term outcome for people with functional limb weakness, but it is a very broad outcome. So 1 in 5 patients had a complete recovery. Probably about 2 in 5 patients had improved to some extent, either a bit or a lot, such that, and even, you know, they'd improved a lot such that the symptoms were still there, but were very much in the background and they could do things. But 2 out of 5 patients really had not improved or were worse. And you're right that many people with FND live with chronic symptoms for a very long time. And that's a difficult thing for us to face, and difficult for patients to face. But we do need to be helping people who are in that situation. As you say, this is often about learning that they have a disabling problem, and they very often have tried really hard to improve it, or health professionals have tried with them, and they've not been able to, and it's not their fault. And you then do need to look at how can you improve that person's quality of life with that problem, in the same way that we do with MS or Parkinson's or brain injuries, I say. So it's a difficult, and in fact we do manage that with MS, for example. There's a very similar spectrum of patients with very mild symptoms to very disabling ones. So we do need that model, I think, applied to FND, and you're right, not always giving a kind of sunny, oh, everything will be fine kind of view about it. That's just not the case.
Well, I think you pointed earlier on that often we encounter people with functional disorders who are very self-critical and have made to feel very responsible for their condition. And I think you do encounter similar ideas with other neurological conditions. So people worrying that stress in their life or things that they've done may have contributed to their illness, but it is something that's particularly pronounced in FND. I suppose the idea that this kind of idea that if you can just do the right thing, or you can just find the right treatment or service, that maybe all of us can go away. And that's maybe something we don't encounter as much even in MS. So we see a spectrum of symptoms, we see relapse remitting patterns, but we don't give people the expectation that the disease is going to be completely reversed, or that they can make a full recovery. So I wonder if that contributes sometimes psychologically to people feeling very self-critical, very hard on themselves, and of course can become a counterproductive trap.
No. I agree. And it's so hard finding that balance in that individual, knowing when has this person really had access to the kind of therapy that might help them? Are we really at the point where we have to start saying, well, this is how things are going to be for the foreseeable future? You need some courage, I think, to make those to say that to somebody, because it's a pretty tough thing to hear. But at the same time, it can be very helpful for some people to hear that. You're right. I personally, I would like more evidence about the treatment to really know when to do that, because I'm not sure we know how effective our treatments can be yet. So that's the other. So I like to keep the window open until if we had lots of high quality evidence, I'd be more comfortable about saying to someone, look, I don't think you personally are going to improve here. But I do feel a bit uncomfortable about that.
Thank you. Okay, we had a couple of other questions that related to the sort of middle concept of functional overlay, and I know this does come up a lot. So Susan had asked about this, and sorry, I can't see it in the list now, but someone else had mentioned and sort of where that fits in terms of FND. So one of the questions was an individual who has other neurological conditions has been told they have a functional overlay, and so they wonder to them, well, conceptually, do I also have FND then, or should it really be seen as part of my other condition? Or
yeah, well, I think you muted. Yeah, so I don't really like the term functional overlay. We don't use the term, you don't say to someone you've got depression overlay, you've got pain overlay. We just make another comorbid, we just make another diagnosis. So for those, if I have someone with MS who I think's got significant disability from FND, I would make 2 diagnoses and just say you've got comorbid FND. And the reason that matters is because I've seen this in my own practice, that if you can change the treatment to FND-oriented treatments, sometimes in some patients you do see benefit when they've been quite static. So it's the same with any part of medicine, really, just recognizing when someone has another problem like migraine or anxiety or asthma or something that's making their life worse. If you treat that, will it help generally? And I think sometimes it does. So and I think sometimes you don't know how much it's contributing until you do the treatment. So I've often said to patients, if I don't know how much of your disability is FND related, what have we got to lose from trying to find out at this point? It would be good if it was, in some ways, it would be good if it was more FND than the MS.
Yeah. Okay. So that takes us up to 11:30. I just want to thank you again for taking the time to be with us this morning. We really appreciate it, and it's been a really informative talk. I recognize also that there's plenty of other questions there, and we'll try to address some of those in the Q&A section. We'll be looking at them through the day. So thank you.
Sorry, can I just say one other thing? Because I noticed someone asked about referral to me, and I meant to mention that. I'm really sorry, but I can't see patients referred from outside Scotland. I only have an NHS practice, just in case anyone was wondering. So I'm really sorry about that. Yeah.
Okay, thank you. So we're going to get about a 10-minute comfort break. Then when we come back, we're going to be joined by Glenn Nielsen, who's going to talk to us about specifically about physiotherapy for FND with motor symptoms and gait symptoms. Okay.